Hello everyone, welcome to one more webinar from NIRx. Today's topic is the objective measurement of tinnitus using functional near infrared spectroscopy. And we have Dr. Shoushtarian presenting this for us. Before we present her and present the team in the background, we have our general manager here today just to talk a little bit about NIRx.
Mari, thanks so much for the quick introduction. Everyone, welcome to our webinar. I want to give you a quick introduction to Nyrex and what we are doing. Since 20 years, Nyrex is in the field of brain imaging, and we design, manufacture the devices here in Berlin. We have a team of scientific consultants that works worldwide with distributors to bring those devices down to researchers and enables research solutions. And if you ask why we are doing that, then why we are building those devices, then the answer is to enable great researchers doing great research. And if you ask my team, our team here, why do we build that for the researchers? Then the answer is something like, well, to allow them to publish Nature and Science publications and do great work. And if you ask again, why? Then the answer is something like, well, to figure out how the mind works and to help people to fix problems, to make life for everyone better. And this is why I'm particularly happy today to have a webinar that is focusing on the clinical potential or on upcoming clinical potential, where we reach this end goal, why we are doing all of that, why the whole stretch comes together of building those devices and helping the people and getting out of publication in the end there to help people. With that, quick introduction, I give it back to you, Mari, and for additional webinar considerations. Thank you.
Thank you very much, Patrick. It's indeed very nice to work with these amazing researchers. Okay, so just to present our team in the back, my name is Maria Delia Ratay. I'm a scientific consultant here. We have also our Christina Theodora, which is our sales support administrator, and also Amy Young, our scientific marketing associate, will be moderating and receiving all your questions in the back. Some of the considerations, so you are muted, but we love to hear from you, so questions are welcome at any time. Please use the GoToWebinar panel for that. And also the content will be available in the upcoming days at our website, nyrex.net/webinars. And if you have any further questions or want to ask anything, please send us an email, at consulting@nyrex.net. Okay, without further ado. So here today we have Dr. Mehrnaz Shoushtarian. She's a biomedical engineer with broad experience in research and development of medical devices used to measure neurological signals and monitor medication effects for diagnostic purposes. She has a PhD in biomedical engineering, and her current role in the Bionics Institute involves using fNIRS in areas of hearing research, such as cochlear implants and tinnitus. Thank you very much, Dr. Shoushtarian, for being here today. The floor is yours.
Thank you very much, Maria.
We see your slides in full.
You do? Okay, great.
Yes, I'm seeing your slides.
Okay, thank you very much for the introduction. As Maria mentioned, today I'll be talking about our research on measuring tinnitus using functional near infrared spectroscopy, or fNIRS, and artificial intelligence. So our research is done at the Bionics Institute, or BI, which is in Melbourne, Australia. And you can see our main building there. It has a name, it's called Mollison. That's where we do most of our research and fNIRS data collection. At the moment, we're in lockdown in Melbourne, so I haven't been to that building for a few weeks, but we're hopeful that we can return very soon. So the Bionics Institute was set up around close to 40 years ago now by Professor Graham Clark, who was the inventor of Australia's multi-electrode cochlear implant. the cochlear implant being a device that's used to provide a sense of sound to a person who is deaf. So BI has a strong background in hearing research. Over the last few years, BI has branched out into other areas, research areas as well, such as vision and other neurological conditions. My own background, as Maria mentioned, is biomedical engineering, and my research interest is using different techniques to measure brain activity non-invasively and extract information to help us understand more about the brain and how it's impaired in different conditions. And tinnitus that I'm going to talk about is a condition which I'll talk about more shortly, but it can be very debilitating to people who experience it. And at the moment, there's no real treatment for it, so there is a lot more we need to understand about it. And over the past 3.5 years, my research has focused on this condition. So some background on tinnitus. As you may know, tinnitus involves hearing sounds which aren't present externally. The sound is described very differently by different people, but it can be a ringing, a humming, a buzzing that in many people is constant. It affects about 1 in 10 adults, although that's quite a conservative estimate. There are reports of higher prevalence rates as well. In 3% of adults, tinnitus is in a severe form. It can lead to depression, inability to work, inability to sleep, and it can reduce a person's quality of life significantly. The number of people who experience tinnitus is predicted to rise due to mainly increased noise exposure among especially young people, but we all have headphones on now all the time, so that's not going to help. It has the condition has significant economic impact. There have been studies that have shown the cost of management is very high, health management. So in the UK, it was estimated to be about £750 million per year. And in a single year, in 2012, it was estimated that disability compensation to US veterans was around $1.2 billion. So it's a serious health condition. You can imagine having a constant sound like that in your ear is not easy to ignore. And the COVID pandemic, there is evidence that it's either made it worse in people who already had tinnitus, and also it's been associated with the onset of tinnitus in people who've had COVID. So it's always been a serious condition, but now there's really a need to look at this further. So for a health condition to be managed well, ideally what's needed is an objective clinical test that can be used to diagnose the condition and also to monitor treatments when they're given. For tinnitus, unfortunately, there is no reliable treatment at the moment. So symptoms are managed through psychological methods and counseling, sound enrichment, but these are all through trial and error, and there is no way to measure their effect to see what they're doing in the brain. So that lack of an objective clinical test is known to be one main reason for no reliable treatments being available. So at the moment, all that clinicians can rely on are patient reports, and these aren't always enough to manage the condition well. So the aspect of this problem that we're working on, as I mentioned, is the objective measurement. And the approach that we're using to tackle this problem is using functional near-infrared spectroscopy as a non-invasive technique to measure changes in blood oxygen levels, and from that infer brain activity. We're using AI algorithms to analyze the data, and I'll talk a bit more about why we're using these techniques. And we're hoping that together with these two approaches, we can develop a measure that can be used to assess tinnitus and how it changes with different treatments. So apologies to all the fNIRS experts on this webinar, but just to keep the flow, I'll quickly mention that fNIRS is a non-invasive imaging technique that uses near-infrared light to measure changes in oxygen levels. And as I mentioned, from that we can infer brain activity. It does this using a montage of sources, light sources and detectors that you can put on a cap on regions that you are interested in recording brain activity from. And the basis is that when a part of the brain is more active, there's an increase in oxygen demand, and therefore an increase in oxygenated hemoglobin, which you can see in this figure down here, and a decrease in deoxygenated hemoglobin. And this is called a hemodynamic response function. So it's a typical response measured using fNIRS, and this is actually a response recorded in a response to 15 seconds of sound. So at the Bionics Institute, the data that I'm going to talk about is recorded using a Nyrex system that you can see here, the Near Scout, with 16 sources and 16 detectors. So why are we using near-infrared spectroscopy? Because a lot of other imaging modalities have also been used for tinnitus research, but we think that fNIRS has a number of advantages that will eventually make it easier to translate to clinical use. And the main advantages are that it's portable, it's fairly cost effective compared to an MRI machine, for example. It's quiet, so it doesn't have the scanner sound associated with MRI, which makes it more appropriate for hearing research. It's safe to use with implanted devices. I'll talk a bit more about that shortly, but we have an interest in studying tinnitus in people who have cochlear implants. So fNIRS is suitable for that. It's non-radioactive, and it's immune to electrical artifacts. So again, if we have participants who have a cochlear implant, they can have their cochlear implant on and working, and that the signals wouldn't interfere with our fNIRS recordings. So you may know the data that we get from fNIRS from each source detector pair or channel, we get a time series recording. This is an example of a time series recording from one channel, and usually, generally, what happens to the data is that we can convert it to optical density using the modified Beer-Lambert law. We convert it to changes in oxygenated and deoxygenated hemoglobin. We perform some pre-processing, artifact rejection, for example, and extract signal features, and perform statistical analysis on those features. So what we're aiming to do in this project is replace those last two blocks with more AI-focused techniques. And what do I mean by AI? So generally, AI algorithms involve three main steps, and that's feature extraction. So for example, that hemodynamic response function that I just showed, the peak amplitude would be one signal feature, one feature that we could look at. But if we are recording from many different source detector pairs on the cap, so we have around 40 channels, that's a lot of signal features. That's a lot of peak amplitudes to work with. So we can use feature selection to pick out the channels that are giving us the most information regarding the question we're asking. For example, difference between tinnitus patients and controls. And then with those features selected, we can use classifiers to classify data from a single subject to either a tinnitus or a control group, or a mild versus severe tinnitus group, depending on your research question. And generally, AI, sort of broadly, AI techniques are referred to as either conventional machine learning, where the feature extraction is more of a manual process, or at least deciding which features you want to look at are manual, and also deep learning methods where the feature extraction part is more automated. So why use AI? What is wrong with conventional statistical methods? Well, conventional statistical methods are used to assess group differences. So while they're important, and that's where we've started from, that wouldn't give us a clinical tool. We can use AI methods for single subject prediction, or taking data from one subject and sort of determining whether the model classifies it as a tinnitus or control group. So this figure here, I think, describes the two approaches quite well. The points that you can see, the data points you can see are simulated data, 100 simulated data points. And here we're looking at either the difference in the average between group 1 and group 2, or where a classification approach where you take a single data point and based on this simple thresholding technique, assign it to group 1 or group 2. So in panel A, you can see that there is a significant group difference in these two groups. But if you take a single data point, the classification accuracy is pretty ordinary. It's only 60%. Whereas in panel B, the group comparison isn't significant. The group differences aren't significant, whereas you get pretty high classification accuracy if you look at a single data point, 94.5%. And in the third panel, you have both high classification or high accuracy. So high group difference, significantly different group difference. So the point here is that having significant group difference isn't necessarily going to give us high accuracy in single subject prediction. So we need to use these AI methods to have a clinical application. So far, talking about our study a bit more, so far we've done 2 studies, and I'll be mostly talking about the data from study 1. So study 1 was a feasibility study to compare fNIRS signals in individuals with and without tinnitus, and also mild versus severe tinnitus. Study 2, which is so far has been just a pilot study, is done on cochlear implant users who experience tinnitus. Now, this valuable group of participants often say that their tinnitus perception is changed with use of their implant. So when they turn their cochlear implant on and off, their tinnitus perception changes. So that gives us valuable within subject data from the same person with their tinnitus perception change. So it can be used to validate measures, our measures that we identify in study 1, and also assess the feasibility of using objective measure as a prognostic tool. But as I said, this is so far has been a pilot study, and I'll be mainly talking about the data from study 1. So for our first study, this is the montage that we use. So this is the way we sort of put the sources and detectors on the fNIRS cap. Now, tinnitus is known to be a condition where multiple regions of the brain are involved. It's generally understood that while it starts off as some damage to the ear, so to sort of more peripheral damage, it quickly becomes more of a central problem with different parts of the brain getting involved. So it's important for us to image as much of the brain as we can. And in previous studies, it's been shown that the auditory regions or brain activity in the auditory regions have been associated with the loudness that tinnitus patients experience, the loudness of the sound, whereas signals from the frontal regions are more associated with the distress that tinnitus patients experience. And so these two are often not related. Someone can have quite loud tinnitus but say, oh, it doesn't annoy me that much. Whereas someone who doesn't describe their tinnitus as being very loud says that just having that sound there can be very annoying and distressing. And the other brain region that we're also collecting data from is the visual region, so the occipital region. And the reason we're doing that is that the corneas, which you can see this green area on this brain figure, is a region that's involved in visual processing in the brain, and it's been identified as having abnormal background activity in patients who have tinnitus. So the data that we've collected for our study has been, I'll talk a little bit about that now. So we do a hearing test, an audiogram from all participants. We go through the tinnitus handicap inventory, which is a questionnaire with different questions about a question and how a person's tinnitus affects different aspects of their life. The answers are then scored, and depending on the range of the score, the tinnitus is sort of rated as slight, mild, moderate, severe, or catastrophic. We also ask participants to rate the loudness and also the annoyance of their tinnitus just on a visual analog scale from 0 to 10. For the fNIRS signals, we record different conditions, so resting state recordings, and also evoked responses to auditory and visual stimuli. And we use a block design. The length of our stimuli is 15 seconds, so visual and auditory stimuli 15 seconds long and randomized, and the rest period between the stimuli is also set to either 20 or 25 seconds. And we collect 10 trials of each stimulus type. Now, we've started simple. So for this feasibility study, we've looked at, well, from both resting state data and evoked responses. For the evoked responses, we've looked at the response amplitude in different time windows. And from the resting data, so resting data is generally used to look at measures of connectivity or how different brain regions interact. In sort of signal processing term, it's looking at the similarity between signals in different parts of the brain. And we've used what's called a seed analysis, where we've picked these seed channels on the left and right in the auditory regions. We actually average the signals from 2 channels on the left and 2 channels on the right, and then look at the correlations between those seed channels and other channels in other parts of the brain. So, for example, a frontal channel here, or an occipital channel here. These are just examples. So we're looking at more frontal channels and more occipital channels. And the measure of connectivity, the widened correlations that I mentioned, is a measure developed by Santos et al. So just sort of give you a brief idea of what we have found so far. In terms of responses, we found reduced auditory responses in the tinnitus group compared to controls. So in the top two figures, these are averaged responses over channels in the left auditory cortex, so looking at the left region of interest, and the right auditory cortex or right region of interest. And averaged across the two, we found a reduced response in the tinnitus patients. We actually also found a reducing, so the blue trace here is from tinnitus patients, and the visual response was also reduced in this group, even though the patients were matched, so the patients and controls were matched for level of hearing and age. So with the auditory responses, the hypothesis is that because there's increased background activity, neural activity in tinnitus patients in the auditory regions, and that's been shown using other studies and other imaging techniques, then because there's already increased background activity, then the response to a stimulus might be reduced. We also found, when looking at the resting state data, we found higher measures of connectivity in the tinnitus group, and the sort of the difference was significant when we looked at the right seed signals and frontal HBO signals and occipital HBR signals. And those again, so increased connectivity has been shown in using different imaging techniques in patients who have tinnitus. Now, for our occipital connectivity, as you can see here, only our HBR signals were significant, not the HBO, and that's certainly something that we need more data for to see why that was the case. Was it a matter of noise, or it's something else going on? So that's something we need to do further work on. So this gives us an idea of group differences, but as I mentioned, for a clinical application, we need to take data from a single subject and be able to sort of have information about that. So when we use those features from the different channels with classifiers, we found that we're looking at tinnitus versus controls gives us a sort of promising accuracy of 75%. And when we look at mild versus severe tinnitus, and that severity is based on the questionnaire that I mentioned, then again, we get fairly good accuracy, although the sensitivity is still low. But this is in a small group of 25 tinnitus patients and 18 healthy controls. We also found that just looking at data from the tinnitus group showed correlations between the widened correlations from HBR and the loudness rating that patients gave based on a visual analog scale. But this was not found for, so these data points did not correlate with annoyance ratings. So we have sort of early evidence to show that we could possibly look at these effects differently, loudness versus annoyance of tinnitus, which would be important for developing treatments that address these two different aspects. Now, what would these be used if we collect further data and our results are reliable and consistent? How could we use it? Well, for clinicians and patients, it would provide key information on whether treatments are working. So trial treatments, especially treatments being developed. At the moment, you can only ask a person, whether it's doing anything. But that might not be enough information to determine whether there's something happening in the brain. It could also help identify subtypes of tinnitus and what treatments each type would benefit from. So at the moment, there's a broad term used, tinnitus for everyone, but tinnitus due to hearing loss as a result of noise exposure could be different to tinnitus as a result of hearing loss just due to aging. So if we can identify the different subtypes using this measure, then that could potentially help develop treatments for each type. It's also been estimated, and this figures are from quite a few years ago now, but that a novel tinnitus drug would have a product value of $689 million in its first year of launch. So, for drug therapeutics manufacturers, there's good incentive to get involved. So what we're doing now, when we're not in lockdown, we're collecting further data and refining our AI algorithms. And that's been possible by generous support from Nyrex. So they provided us with a NearSport 2 system for 6 months, which was just used for this tinnitus project, and really helped increase our data size. And we're also, so I mentioned that we've collected pilot data on cochlear implant users. So we're hoping to get more funding to perform a full study in this valuable sort of group of tinnitus patients. Now, one question we get a lot is that we're using subjective questionnaires to sort of developing our algorithms, which we say will be objective. So how does that work? Well, as a first step, because there is no tinnitus measure or clinical test at the moment, as a first step, we need to do that. We need to just identify signal features that will separate the groups and sort of identify features associated with tinnitus, even though it's subjective ratings of tinnitus. But from there, we can then move on to recording or looking at effects of treatments or devices such as cochlear implants in a single subject and getting data with the cochlear implant on and off or before and after treatments, so to be able to track tinnitus changes in the same person. That's sort of our ultimate goal. And how we aim to actually get this to clinics translated. So as I explained, we're at the research phase and working out how best to analyze this data and what the best features are. And so therefore, we have filed a patent we have filed a patent as a first step. In terms of commercialization, our management at the Bionics Institute has experience in a number of fields. So one is to create a startup with the Bionics Institute and others to attract investment and then continue development of the program. And this model has been used successfully in a number of our other projects over the past 2 years. Another approach is to license this approach to interested parties and then continue development with the licensee and the Bionics Institute involved. So there are different options. We're looking at all. We haven't we're not stuck in a single approach at the moment. The other thing that we need is purpose-built hardware. So at the moment we're using a research system. which would be expensive and sort of bulky to use in a clinic. So we need fNIRS hardware with our algorithms integrated, which would lower the cost and also make it more practical to use in a clinic. So our overall aim is to give clinicians and researchers the ability to track the complex changes that tinnitus triggers in a sufferer's brain. And such a tool is a critical first step for development of new treatments and for determining what treatments should be used on what patient groups. As you know, these projects, there is a whole team involved. Robert Klupax is our CEO at the Bionics Institute. He has a lot of experience in commercialization of research and is working hard to move this project forward. James Fallon is our research director, who has a lot of experience in auditory neuroscience and is also involved directly in the project. Errol Harvey is our head of development. He also has experience in startups and growing them and commercializing research. We have two researchers working with us, Michelle Bravo and Shreya Siddhartha. And also we have collaborators at the Institute for Intelligent Systems Research and Innovation, which is part of Deakin University here in Australia. They have great experience in artificial intelligence and have been collaborating with us in this project, helped us develop our early algorithms and are still working with us now. We are applying for further funding for this work, especially our cochlear implant study. We are, as many researchers on this webinar will know, funding is not the easiest part, but we're working hard on it. So thank you very much for listening. I appreciate your time joining the webinar and would be happy to take any questions.
Thank you very much, Dr. Shoustarian. That was a really interesting webinar, interesting research. We do have a couple of questions. One question, actually, it's I think you just said that you answered this a lot, but this objective measurement of, you know, how to know how is the impact of the tinnitus in one of the patient in the patients. And one of the questions, have you considered, for example, using kind of skin response or heart rate that, you know, can measure distress as well with the fNIRS to try to classify?
Yes, so one of our researchers that I had named on the slide, Shreya Siddhartha, she has a lot of experience in recording heart rate variability, skin conductance, changes in skin conductance, using sort of simple wearable wrist monitors. So we are looking at integrating that into our data set as well to help us further highlight those signals associated with the distress related to the tinnitus rather than the loudness.
Yeah, this is very interesting because we know that there are some researchers using this kind of signals to kind of clean the fNIRS data, you know, to try to make the fNIRS data a bit cleaner, but it can also be used in your context, like really to classify what stresses the person more or less. So it's very, very interesting in that. We are also working on this kind of integration to help on this context. So very interesting that. Another question about it's about, can this also assist or in the diagnosis of or maybe treatment of somatic tinnitus?
Yes, so somatic tinnitus, I guess the short answer is we don't have data from that group of patients, so I couldn't tell you accurately. But because fNIRS measures sort of cortical or we measure activity from cortical regions, superficial cortical regions, and not sort of more subcortical areas. It could be that we can't, we wouldn't be able to measure any sort of direct evidence of somatic tinnitus, but we could likely be able to sort of identify it as a type. So if a person says they have tinnitus, but your signals are showing that they don't, or your signals are not similar to some other form of tinnitus, then it could be because it's sort of more somatic in region. So I guess no single imaging technique, I think, is going to give us all the answers for tinnitus, but it can certainly help rule out things or identify sort of clusters or subtypes that would help management of the condition.
Yeah, interesting. Do you believe, that's a question of mine actually, but do you believe that if you image from more regions of the brain, that you could try, you know, like you could try to classify better also this kind of somatic in all the regions that you already identified that are connected with tinnitus? Yeah, maybe.
Yes, I think imaging from sort of broad different regions of the brain is going to give us more information. We are also trying to figure out which brain regions it is that are critical, because from a sort of practical clinical aspect, you need to have something that's quick to put on and sort of comfortable for the patient. So we may not be able to have all 40 odd channels that we record from at the moment in a clinical setting. So we've got to get the balance right between something that's possible, practical to use in a clinic, but also gives us information from different regions of the brain about tinnitus.
Indeed, the practicality of the clinical, it's a very point that you need to consider. On a question about also this classification, we had a question about the scale of the measurement. So I believe that that's your like end goal would be like to have a scale where you could really see if that person is less affected or more affected. Is that something that you foresee?
That's right. Yes, definitely. So just classifying mild versus severe. So in that subjective questionnaire, we sort of took the first two slight and mild, and as one category, and moderate and severe as another category, just because we had a small sample size. But the aim is definitely to be able to sort of refine that so that we can better, as you said, have a scale rather than just two broad categories.
Interesting. We do have in the audience actually some people suffering from tinnitus, and one of the questions that if this method would also work for someone that's been suffering for more than a year or 4 years, things like that. If you have researched that or intended.
Yeah, we have looked at the effects. So the right now as I said, we've collected more data, and we've got sort of a range of durations, number of years that people have had tinnitus, and it looks like our initial evidence is that we can still pick it up if a person has had tinnitus for a longer period as well.
Interesting. I guess it's very good to hear that will also serve for people that have tinnitus for a long time. One question then more about the processing. How much data training you need or you use to be able to use the AI with fNIRS data?
Yeah, that's a good question. AI is data hungry. Well, what we've been doing so far is just making sure doing the usual checks with these, that we don't have models that are overfitted, that we can use. So we use cross-validation, we sort of split the data up into training and testing, and that's becoming more feasible as our data size is growing. So yes, it's hard to know exactly how much data we would need, but as our data is growing, we can see how the performance is also improving.
Interesting. One other question, actually, people want to know a bit more about your findings showing some activity in the cuneus area in the tinnitus sufferers.
Yeah, so, well, I guess the background or the known literature around that is that the cuneus shows just doing sort of background, so not evoked recordings, but background recordings using different techniques has shown that, and this I think in a meta-analysis, so looked at a few different studies, and in a lot of them, the cuneus was identified as a region of the brain that showed abnormal activity in tinnitus patients when compared to controls. So we think that that might have something to do with our visual response in the tinnitus group being smaller, reduced compared to controls. So one reason is the abnormal background activity. The other reason is because there are strong and sort of known auditory visual pathways in the brain that are known to be affected by tinnitus. So because of that abnormal activity in the auditory regions, it seems that auditory visual pathways are also affected, which again could be affecting our visual responses.
That's very interesting. Yeah. We have some last questions, and all of them are actually connected to the treatment. So we have some researchers in the audience that do protocol for treating tinnitus with TMS, and of course TMS is compatible with fNIRS, so you would be able to kind of do some things like this. I want to just to know if you have tried or if you think that this could be a possibility for the future.
Yeah, I think it could definitely be a possibility, and yes, we'd be interested in hearing from them. We have spoken to a couple of TMS groups here in Australia, just very initial sort of early stage conversations. But yes, that's a big advantage of fNIRS for this type of treatment, is that it wouldn't be affected by the signals, so there wouldn't be interference. So potentially, yes, we could look at the effect of TMS, so doing pre and post, for example, fNIRS recordings with TMS as a treatment.
Interesting. And one last question then just came in, again about some computational. So just we're interested in about computational needs for AI data processing. How much computer power is required, and does it work in real time or post processing? I guess it's also very important for the clinics.
Yeah, so at the moment it's post processing. So we collect the data and then move it into either MATLAB or Python, or and do the processing there. So at the moment it's all post processing, but ideally in a clinical application, you would want something more real time that could generate a clinical report for a clinician, you know, within a very short time after the test is done.
Mm-hmm. Very similar it works like with an MRI today, like you do the imaging and then some days later maybe you receive your result, your diagnosis, or something like this. Okay, very interesting. I think this was the last question. We have a lot of thank you from the audience, and you know, thank you for this new research. People are looking forward to it, and even looking for the commercial available product maybe in a couple of years.
Yes, hopefully, yeah.
Yes, that would be definitely an amazing groundbreak for this research area. So again, thank you very much, Dr. Shoustarian. It was really, really nice having you here. Everyone is thank you, like I said before. And if you have any other questions to Dr. Shoustarian or to us, just please send us an email. She also put her email there, so if you want to also get in contact, we are also happy to help there. Yeah, follow us in our social medias, and we have more webinars prepared for you the next couple of months. Thank you very much, Dr. Shoustarian, again, and good luck in your research.
Thank you, Maria, and also thank you for to yourself and your team at NIRx for this webinar, but also for your support with the research that I mentioned. Much appreciated.
Perfect. Thank you. Bye.